Assalamu alaikum. This is me, Dr. Faiza here, with the next session of Endocrine Physiology. Today, our topic of discussion is Adrenocortical hormones. So let's begin our discussion. To cover this topic, I will be using references majorly from the Guide 10, chapter number 78, and also few references from Genong, Sherwood, and BRS Physiology. So let's begin our discussion of adrenocortical hormones. To review your previous sessions, we have covered the general endocrinology, pituitary hormone, and thyroid hormones. Today we are going to discuss the adrenocortical hormones. As is evident by its name, hormones from the adrenal cortex. So starting from what adrenal glands are. These are the endocrine glands present close to the right and left kidney at their superior poles on the both sides. Histologically, adrenal glands are composed of adrenal cortex and inner portion contains medulla. Today we are going to focus majorly on the adrenal cortex, adrenocortical hormones. Adrenal medulla, we will be quickly reviewing it, although this is discussed in much detail in combination with the autonomic nervous system, because the hormones produced from adrenal medulla are epinephrine, norepinephrine, the catecholamines, which are also released at the nervous endings of autonomic nervous system, and both of these together work in case of need. So our major focus today is adrenal cortex. Let's have a look at the layers of adrenal cortex. From outer to inner side, there are three layers: zona glomerulosa, fasciculata, and reticularis. Also, you can see the changing histology, their size and shape of the cells, their staining characteristics, and the proportional width of these layers. The largest width is of zona fasciculata. Starting from zona glomerulosa, this is the only layer in the adrenal cortex which is going to produce aldosterone, the prototype mineralocorticoid. The reason behind is only this layer contains aldosterone synthase. Zona fasciculata and reticularis do not have this aldosterone synthase. 15% of the adrenal cortex is zona glomerulosa. Moving on, zona fasciculata and zona reticularis, both of these are going to produce glucocorticoids, among which the most important is cortisol and androgens. 75% of the production is going to be from these layers, and mostly adrenocorticotrophic hormone is going to regulate the production of these hormones from the zona fasciculata and reticularis. Whichever the steroid hormone is produced from the adrenal cortex, may it be mineralocorticoids, glucocorticoids, or androgens, all of these are going to be produced from a single precursor, which is cholesterol. One thing more I should define over here, that both the fasciculata and reticularis produce cortisol and androgens, but still there is some differentiation. Fasciculata is going to majorly produce cortisol and little bit of androgens, whereas reticularis is going to majorly synthesize androgens and somewhat of the glucocorticoids. Moving on towards the synthesis of steroid hormones, as we discussed in our first lecture, the precursor for which is cholesterol, and this cholesterol is obtained from the LDL, low density lipoprotein. This is synthesized in various intracellular compartments, but most importantly, mitochondria and smooth endoplasmic reticulum are involved. The first step in synthesis is to obtain cholesterol from the LDL, and once cholesterol is obtained, the synthesis of steroid hormones start. The first step is to move the cholesterol through the mitochondrial membranes and convert it into pregnenolone. This is the rate limiting step. And this is expedited by the Adrenocorticotrophic hormone, stimulated by the Adrenocorticotrophic hormone. This rate limiting step, the conversion of cholesterol to pregnenolone, after which the precursors and substances until the production of final hormones are going to be shifted many times between the mitochondria and the smooth endoplasmic reticulum. This is again showing the same thing, shuttling of intermediates between the mitochondria and smooth endoplasmic reticulum. Once the steroid hormones are synthesized, they simply diffuse outside the cell. Steroid hormones are not stored, but their precursor, cholesterol, is stored within these cells, and the hormones are produced and released whenever there is stimulus for their release. Another thing we can see, cholesterol precursor is coming from the LDL, but some amount of cholesterol can be de novo synthesized within the cells from the acetate. Although this one is the major precursor, and this should be remembered at any cost. Cholesterol is the precursor which can be converted into mineralocorticoids, glucocorticoids, or androgens in various layers of the adrenal cortex, as shown in front of you. All the steroid hormones are going to have this cyclopentanoperhydrophenyltranine nucleus in combination, and with little bit of variations, different type of steroid hormones are produced. One thing you can clearly see over here, that glucocorticoids, mineralocorticoids are 21 carbon derivatives. The androgens are 19 carbon derivatives and estrogens are 18 carbon derivatives. Why are we discussing this? This we will look in this slide. So let's have a look at the synthesis of steroid hormones. So it looks like a busy picture, might be overwhelming for you, but don't worry, we are going to look at it step by step and this will become easier for you. So this is here, it is starting from the cholesterol. And the first step, the rate limiting step, is its conversion to pregnenolone here. And this is promoted by this enzyme, cholesterol desmolase, which is stimulated by adrenocorticotrophic hormone, which is coming from the anterior pituitary. Once the pregnenolone is formed, it has two pathways, either go rightwards or downwards. So let's have a look at the downward pathway first. Pregnenolone is converted into progesterone, which is then converted into deoxycorticosterone and ultimately into corticosterone. This corticosterone can be acted upon by aldosterone synthase to form aldosterone, and this is only going to happen in the zona glomerulosa. This enzyme is not present in the other layers, so this step cannot be completed in other layers of the adrenal cortex, whereas the rest of all the reactions can happen in any adrenal cortical layer. So cholesterol, pregnenolone, and by going through various intermediary substances, it is converted into corticosterone, which can be converted into aldosterone. Other pathway the pregnenolone can acquire is shift rightwards. It can be 17 hydroxylated, 17 hydroxypregnenolone. Each substance, intermediary substance, can be hydroxylated by the same enzyme, 17 alpha hydroxylase, to form 17 hydroxypregnenolone, 17 hydroxyprogesterone, 11 deoxycortisol, and the ultimate product we can see over here as Cortisol, which is the prototype glucocorticoid. Third thing that can happen is the reaction can still further go towards the right side and acted upon by another enzyme, 1720 lyase. If this acts, androgens can be synthesized. Dehydroepiandrosterone and androstenedione. These two are the major androgens produced within the adrenal cortex. Once androstenedione is produced, it can go to the peripheral tissues and can be converted into testosterone, but this is not going to be formed within the cortex. Also, this testosterone can be converted in the peripheral tissues, for example, in adipose tissue, with the help of an enzyme, aromatase enzyme, to estradiol. So, the androgens produced by the adrenal cortex are the only source of androgens among females. These are responsible for pubic and axillary hair growth among females, whereas among males, this is a secondary source of androgens. Major source are the testes. But this conversion to estradiol provides a source of production of estrogens among males, because estrogen is not going to be directly produced by the testes. Again, testosterone is produced by testes and that can also be converted into estradiol. So this is not the only source. Let's have a look at the enzymes. 17 alpha hydroxylase and 17-20 lyase to shift the reactions rightwards. From upward to downward, which enzymes are involved? Let's have a look. Number 1, a dehydrogenase enzyme, 3-beta hydroxysteroid dehydrogenase. Number 2, another hydroxylase, 21-beta hydroxylase. And lastly, 11-beta hydroxylase. So, dehydrogenase, hydroxylase, this is also hydroxylase and this is lyase. If you don't find it easy to remember all the intermediary substances, that is perfectly fine. But keep a mind map. Starting from cholesterol, pregnenolone, downwards you go mineralocorticoids, rightwards glucocorticoids, further rightwards androgens. But you need to remember the enzymes involved. 17 alpha hydroxylase, lyase, dehydrogenase, then hydroxylases. Why? Because once we are going to discuss the enzyme deficiencies, if 17 hydroxylase is absent, you can simply guess that aldosterone will be produced, but glucocorticoids and androgens will not be formed. Another example, if 21 beta hydroxylase is absent, this can go, but ultimately these steps will not be happening. So if you have a mind map, where are these enzymes in this pathway, you can tell the deficiencies and the symptoms of the enzyme deficiencies. So for now, steroid hormone synthesis, all the three pathways starting from cholesterol, rate limiting step, ACTH. Another important thing that I would like to mention over here, the aldosterone synthase. This is not directly promoted by the adrenocorticotrophic hormone, but more potently promoted by the angiotensin 2. Renin, angiotensin 1, angiotensin 2, and that angiotensin 2 then leads to stimulation of aldosterone production. So this is here, aldosterone is enhanced and stimulated by angiotensin 2. Okay, this is again the summary of important products: cholesterol, pregnenolone, progesterone, which may be shifted towards production of glucocorticoids or androgens. If shifted rightwards, downwards, it is shifted towards the production of aldosterone. You can see the angiotensin 2 promoting aldosterone synthase on the way. Also, this rate limiting step is not only promoted by adrenocorticotrophic hormone but also by the angiotensin 2. So even if there is no adrenocorticotrophic hormone or less adrenocorticotrophic hormone, angiotensin alone can stimulate the production of aldosterone by the adrenal cortex. But the importance of ACTH cannot be denied for mineralocorticoids. If it is absolutely absent, the adrenal cortex will atrophy and ultimately the aldosterone production will decrease. So ACTH, if not primarily required, still has a permissive role in production of mineralocorticoids stimulated by angiotensin 2. Here is the list of mineralocorticoids and glucocorticoids. Aldosterone, the prototype mineralocorticoid, and cortisol, the prototype glucocorticoid. 90% and 95% of mineralo and glucocorticoid activity are performed by these. The rest is a long list which can perform mineralocorticoid and glucocorticoid. Some of them are the synthetic steroids which are used medicinally. For example, I would like to mention the dexamethasone. Dexamethasone is 30 times as potent as cortisol. And the other important thing is this is synthetic and used in medicine very frequently because it has a strong glucocorticoid activity and no mineralocorticoid activity. Rest you can see even the naturally occurring steroids have mixed activities, both the glucocorticoid and mineralocorticoid potentials. That can be more or less. For example, aldosterone's glucocorticoid potential is close to negligible, and rest of you can compare by yourself. So this is the synthetic mineralocorticoid which you need to remember, and this is the synthetic glucocorticoid that you should be remembering because of their potencies. Cortisol, if you look at it, this is the prototype glucocorticoid, but it has a high mineralocorticoid activity too. So if there is excessive cortisol production for some reason in the body, cortisol will not only give to the symptoms of glucocorticoid excess, but also the symptoms of mineralocorticoid excess. Although this is itself a glucocorticoid, but it can stimulate both the receptors of glucocorticoid and mineralocorticoid. Steroid hormones are lipid soluble. These cannot be dissolved in the plasma. So to move across the blood, they need to have a carrier with them, which are the plasma proteins, mostly globulins, some transportin, and a little bit of albumin. Most importantly, globulins. So in the blood, you will find both the free cortisol and protein-bound cortisol. And again emphasizing only this free cortisol is the active form of the hormone. This is what is going to produce the actions of cortisol, and this is what is going to give feedback regulation to anterior pituitary and hypothalamus will only by this free cortisol levels. Another important aspect of binding with plasma, we discussed in the first lecture that binding with the plasma increases the half-life of the hormone because it decreases the clearance of the hormone. So you see cortisol is almost 95% found in the bound form. Its half-life is 60 to 90 minutes. Aldosterone is relatively less, 60% in bound form. Its half-life is relatively less, 20 minutes. Free cortisol is the active hormone. This is going to produce action. This is going to give the feedback regulation. But the bound form, this has its importance too. This is providing a stable storage full of that hormone. Moving on, production of hormones is not only regulated by positive negative feedback regulation, but also there are other factors, one of which is shown in front of you, which is the diurnal variation. Plasma, cortisol, and ACTH increase early in the morning. You can see the peak, and midnight is the lowest value. For growth hormone, it was opposite. It was increased excessively in the early hours of deep sleep. whereas cortisol is maximum early in the morning and mostly just before you wake up. Okay, let's discuss the functions of these hormones one by one. Before moving towards that, whenever you are studying a hormone, preparing for your exam, or understanding the concept of a hormone, what you need to know: the source of production of that hormone, regulation of production of that hormone, that will involve hypothalamic pituitary axis, maybe the stimuli and inhibitors, which are other factors, diurnal variations, neuroendocrine regulation, and receptor of that hormone, mechanism of action of that hormone, half-life of that hormone, free and bound form comparison, and lastly, abnormalities of that hormone. So एक बहुत important miss हो गया, that is functions of that hormone, functions and abnormalities, excess production and deficient production. So we have seen this production of these hormones and receptors, mechanism of actions of steroid hormones we have discussed in the first lecture, half-life, and this we have seen. Next, we are going to focus upon function of mineralocorticoids and sequential regulation, and lastly, their abnormalities. These three things we are going to discuss in the coming slides, and this is what you need to understand and remember for your exams too. Starting from mineralocorticoids, which are produced from the zona glomerulosa of adrenal cortex. Most important one is aldosterone. Majorly, this is doing 90% of the mineralocorticoid activity in the body. One of the pathway by which aldosterone is stimulated is renin, angiotensin, aldosterone pathway that you have seen in detail in your renal physiology. So let's discuss it with the help of one stimulus, which over here is okay. Let's start. If there is decreased GFR, decreased delivery of sodium chloride to macula densa, tubuloglomerular feedback will lead to the production of renin. This renin will convert angiotensinogen to angiotensin 1. Angiotensin converting enzyme in lungs will convert this angiotensin 1 to angiotensin 2. And now this angiotensin will act on the adrenal cortex to lead to the production of aldosterone. What will this aldosterone now do? Majorly, it will lead to sodium and water reabsorption. That will lead to increased extracellular fluid volume. That increased fluid volume will increase the mean arterial pressure, and that will make the GFR come back to normal. So this is how renin, angiotensin, aldosterone system works, and by this we have found one stimulus of aldosterone production, which is plasma volume. If plasma volume is less, if there is dehydration, if there is blood loss, extracellular fluid volume decreases, it will lead to increased production of renin, which will lead to increased production of angiotensin, and that will stimulate the production of aldosterone. So increased renin will produce aldosterone, decreased plasma volume will stimulate aldosterone. ACTH is cannot be denied. This is going to stimulate the adrenal cortex to produce all the hormones. Potassium, where does it fit? Aldosterone stimulates the reabsorption of sodium, whereas it stimulates the secretion of potassium. So whenever there is hyperkalemia, aldosterone will be stimulated. Whenever there is hyponatremia, aldosterone will be stimulated. Atrial natriuretic peptide is produced when there is excessive plasma volume. For example, in congestive cardiac failure, volume overload, atrial natriuretic peptide will be produced and it will inhibit the production of aldosterone. The rest are the stimulators and ANP is the inhibitor. ACTH, hyperkalemia, dehydration, decreased plasma volume, decreased sodium content, and renin-angiotensin. If you are asked about the most potent stimulus, you can go for potassium or endurance. These two are the most potent stimulants for production of aldosterone. And this is what we have already discussed, the permissive but not compulsive action of ACTH for production of aldosterone. In the previous slides, this one, we saw that many of these hormones do not separately have glucocorticoid or mineralocorticoid activity. Specifically, cortisol has both the glucocorticoid and mineralocorticoid activity. Although cortisol potency is less, but it is produced in such a large quantity in the blood that overall its action becomes significant. So this slide is discussing this detail. Cortisol is a mineralocorticoid, is having mineralocorticoid effects too. To decrease that effect, cortisol is converted into cortisone. This cortisone is inactive at mineralocorticoid receptor but still active as a glucocorticoid. So among these areas, kidney, colon, sweat glands, and salivary glands, where absorption of sodium matters a lot. In these organs, cortisol is converted into cortisone so that only sodium is reabsorbed by aldosterone, not by the cortisol. And who is doing that? This enzyme, 11 beta hydroxysteroid dehydrogenase 2. This cortisone, when reaches these organs, liver, skin, brain, adipose tissue, and placenta, this is converted back into cortisol, which is more potent glucocorticoid and also a mineralocorticoid. And this is done by the same enzyme, different isoform, 11 beta hydroxysteroid dehydrogenase 1 this time. So all those diseases which are producing excessive cortisol might lead to symptoms of mineralocorticoid excess too. And all those diseases or conditions in which this enzyme is deficient or defective are also going to production symptoms of mineralocorticoid excess. A very simple condition is the presence of this compound, glycyrrhetinic acid, in the food, which if taken in larger amounts can lead to inactivation of this enzyme, 11 beta hydroxysteroid dehydrogenase, which leads to the apparent symptoms of mineralocorticoid excess, whereas mineralocorticoids itself are not in higher amounts. That is why it is called as apparent mineralocorticoid excess. We were talking about aldosterone. We have seen from where these are produced, what are their stimuli, and now we are looking at a diagram which is showing the mechanism of action. Aldosterone is lipid soluble, moves into the cytoplasm, binds to its receptor. That complex moves into the nucleus, binds to hormone response element, ultimately modulating the genetic expression, transcription, and translation. Specifically, you can see 3 channel proteins. Genetic translation is increased by the aldosterone. Epithelial sodium channels, sodium potassium ATPase, and these potassium channels, ROMK channels, and all this is occurring in the principal cells of collecting tubules. If you remember from your renal physiology, principal cells and intercalated cells. So in principal cells, aldosterone is responsible for number 1, increased sodium reabsorption. for which it requires epithelial sodium channels and sodium potassium ATPase. Number two, you can see increased potassium excretion. So aldosterone is leading to increased synthesis of all these channel proteins. There are other functions of aldosterone also. In addition to sodium reabsorption, whenever there is sodium reabsorption, water will follow and that will lead to fluid retention to potassium excretion. And among the intercalated cells, it is also going to promote hydrogen excretion. Most lead section is within the principal cells of renal tubules. Other than that, among colon, salivary glands, and sweat glands, it can also promote the sodium reabsorption, hydrogen, and potassium excretion. Again, summarizing the effects of aldosterone: sodium reabsorption, water will follow, potassium secretion, and hydrogen secretion. And hydrogen secretion means attaining extra bicarbonates. So if you see aldosterone is produced adequately, all this will happen as per requirement. But if aldosterone is produced excessively, what you can have? Excessive total body sodium, hypokalemia, loss of hydrogen ions can lead to alkalosis. Attainment of excessive bicarbonate again can lead to alkalosis. More and more water absorbed, more than what was required, can lead to water retention, volume expansion, more than what is required. So if you simply know the functions of aldosterone, you can guess the symptoms of aldosterone excess. And also you can guess the symptoms of aldosterone deficiency. If there is decreased aldosterone, total body sodium will decrease, there will be hyperkalemia, there will be acidosis, there will be loss of bicarbonates, there will be loss of extracellular fluid volume. And all that can be reversed if there is excessive aldosterone. This is again showing the comparison of adrenal insufficiency and excessive aldosterone production in comparison to the normal, the same what we have already discussed. Another implication, hyperkalemia, hypokalemia, you know from your previous knowledge of nerve physiology and cardiac physiology. Action potentials, potassium is very important. Both hyper and hypokalemia, specifically hyperkalemia, can lead to arrhythmias. Hypokalemia can also lead to muscle weakness and transient muscle weakness. Even if there is excessive hypokalemia, can lead to transient paralysis episode of the muscles. Hyperaldosteronism, we have decided sodium zyada, more water reabsorption, decreased potassium, decreased hydrogen ions, but there is one step further to this concept. Let's have a look at it. This is a graph from Guyton, which is showing three things on the y-axis: mean arterial pressure, extracellular fluid volume, and urinary sodium excretion. And in the center portion of this graph, aldosterone levels are increased. Once the aldosterone is increased, you can see mean arterial pressure is increased, sodium retention, water retention, increased extracellular fluid volume. It is understandable that it can lead to increased arterial blood pressure. But there is little effect on plasma sodium concentration. Why? जब हमने कहा, once we said that sodium is more, we said total body sodium has increased. For example, if the total amount of, just talking about the hypothetical terms, was 50 grams in normal person, after excessive reabsorption, sodium might be now 80 grams in this person in which there is excessive aldosterone. But the water is reabsorbed along with this sodium. If sodium is increased from 50 to 80, total body fluid volume might have increased from 60% to 70% of total body water. Ultimately, what happens is concentration of sodium is not different. concentration per unit volume of the water is still the same because both has increased, sodium and the water. So be very mindful while answering such questions. Total sodium content of the body has increased, but the sodium concentration is not much different. Aldosterone deficiency, if it is there, that will lead to hyponatremia. That will lead to hyponatremia because there are other mechanisms which can lead to reabsorption of water. For example, antidiuretic hormone. So the water might still be reabsorbed, but sodium is not being conserved. So hyponatremia can be caused, but hypernatremia is less likely. Another important thing, we have said total body fluid volume has increased, extracellular fluid volume has increased, but usually peripheral edema does not occur. Why? Because of this aldosterone escape. A very important concept to comprehend over here. Aldosterone escape. Aldosterone is still higher in level. It is still causing excessive sodium reabsorption and water reabsorption. But ultimately, what happens? This starts happening. Pressure natriuresis. Pressure diuresis. How it will happen? One, it can be explained with the help of the Starling forces at the level of renal tubules. More the blood volume, more the hydrostatic pressure, more will be GFR and more will go into the renal tubules. If there is more delivery to the renal tubules, there will be less production of renin, angiotensin and aldosterone and less reabsorption. Pressure diuresis has started. Another important thing, whenever there is fluid overload, this atrial natriuretic peptide will be start producing, which will lead to sodium excretion. So despite the high aldosterone levels, urinary sodium excretion, which was first decreased, will then start increasing despite the excessive aldosterone. The reason is pressure natriuresis, pressure diuresis, atrial natriuretic peptide, Starling forces in combination, this is known as aldosterone escape. So after aldosterone escape, what we will find? There will still be hypertension. Total body content of sodium might still be high. Still there will be hypokalemia. Still there will be alkalosis, but there will be no edema, no hypernatremia. So a tricky concept to understand. Conditions that increase aldosterone, the stimulants which we have already discussed, this is one step further to that. All these things are going to fit in somewhere. Increased aldosterone secretion along which glucocorticoid secretion is also increased. These are all those conditions which are going to increase ACTH production. Whenever there is stress, trauma, surgery, hemorrhage, all the stress conditions, there is stress response, ACTH is increased, and that will stimulate both the production of glucocorticoids and mineralocorticoids. But there are certain situations which are not going to stimulate aldosterone production via ACTH, but via angiotensin 2 maybe. For example, high potassium, low sodium, and you can leave the rest for now. Standing, cooling of the blood, or again, this will stimulate angiotensin 2 production. Baroreceptor reflex, if you remember. And secondary hyperaldosteronism. This is a pathological condition. Let's leave it for now. We will be discussing it in a while. So that was all about the mineralocorticoids. Let's move on towards the next category of steroid hormones, which are glucocorticoids, produced mostly from the fasciculator and somewhat from the zona reticularis of the adrenal cortex. Most important glucocorticoid, cortisol, the other name for which is hydrocortisol. How is it stimulated? ACTH is going to enhance its production, And stress, trauma, emotional stimuli, these three are going to stimulate hypothalamus to release corticotrophic releasing hormone that will again produce more and more ACTH. Hypothalamus is also a part of limbic system. So whenever there is emotional trauma, there is pain, there is going to be stimulation of hypothalamus and production of this stress hormone. The diurnal variation, as we discussed earlier, limbic system in connection with this and this, again will lead to increased production of corticotrophin releasing hormone from the hypothalamus. Let's move on to the functions of cortisol. If you are asked about the functions of the hormone, look at the marks you are allotted. If it is a short question or it's a short viva question, limit your answers to the resultant effects. For example, increased glucose production, increased protein deposition, decreased lipolysis, good enough. But if it is a detailed answer question, then you need to know the mechanism too. And again, for the MCQ's point of view, only the resultant is not going to be enough. You need to know what were the mechanisms behind these. So let's discuss these one by one. And one other important thing, whenever you are asked about the functions of a hormone, you might be asked about simply the functions or about the metabolic functions. If it is about metabolism, you can limit your answer to this: carbohydrate, protein, and fat metabolism. It can also be stated as intermediary metabolism. And if you are asked about the functions, that you can enlist as many functions as you know. So let's start from the metabolic functions, starting from the carbohydrate metabolism. Again, cortisol is a diabetogenic hormone, like growth hormone. Growth hormone was diabetogenic because it promoted gluconeogenesis in the liver, and that also decreased glucose utilization in the liver. Cortisol is again a diabetogenic hormone. How? It is again going to promote hepatic gluconeogenesis. What gluconeogenesis is? Production of glucose from other substrates like amino acids. Secondly, mobilization of amino acids from extrahepatic tissue. It's bringing the substrate. Amino acid is coming into the muscles from outside, that is providing the substrate for gluconeogenesis. So it's making the environment favorable for hepatic gluconeogenesis. The enzymes and the substrate both are increased by cortisol. Antagonizes the insulin effect. Anti-insulinic effect, it is decreasing the glucose utilization, the same as that of growth hormone. By decreasing glucose utilization, decreasing insulin sensitivity, increasing hepatic gluconeogenesis, cortisol is promoting increased blood glucose level. So ultimate result will be increased blood glucose levels. If we look at the protein metabolism, it has some preferential effect, different in hepatic and extrahepatic tissue. What it will do, it will increase the hepatic production of proteins. It has caused the metabolization and movement of amino acids into the liver. Those amino acids will provide a precursor for gluconeogenesis and also for the production of proteins in the liver. So production of liver and plasma proteins will be increased. Enhanced transport of amino acids into hepatocytes, again the same. And lastly, decreased synthesis and increased catabolism of extrahepatic proteins. Hepatic protein synthesis is increasing, extrahepatic proteins catabolism is increases. So this is a preferential effect between the hepatic and extrahepatic tissue. If there is excessive cortisol production, muscle proteins might be catabolized, and that can lead to muscle weakness. Cortisol is a stress hormone released in the stress when the body will not worry to conserve the substrates, to rather provide the substrates to provide the energy to the body for this fight and flight condition. So it is providing glucose to the brain and the heart not storing it in the form of glycogen. It is conserving the extremely required proteins, producing more liver and hepatic proteins, but preferentially catabolizing those proteins which might not be necessarily required immediately. Moving on towards the fat metabolism, again, like that of growth hormone, cortisol is going to shift the energy providing function to the fats. It will increase lipolysis in the adipose tissue so that the free fatty acids are available in the blood, and those free fatty acids can be utilized for energy. And there is again something more to it. If there is excessive cortisol, in spite of the lipolysis, there might be obesity. Why is that so? Well, that has many explanations. One of it is cortisol enhances lipolysis in some areas of the body and lipid deposition in other areas of the body. And another explanation is because it increases lipolysis, it also increases the appetite. So because of increased food intake, obesity is caused. So you can give the explanation by both of these. Ultimate fat metabolism affected होगा तो there will be increased free fatty acids available for providing energy. A very important aspect, anti-inflammatory effects. It prevents inflammation, and if there is inflammation, it can resolve the inflammation. This is what I hope all of you know already. It is used in various diseases to treat inflammation. For example, in rheumatoid arthritis, for example, in pneumonia, for example, in asthma, for example, in COVID-19, it was used sparingly. So it has anti-inflammatory and anti-allergic potential both. How it acts like that? Many reasons. It stabilizes lysosomal membrane. That decreases the inflammatory products, decreases the migration and phagocytosis by white blood cells. It suppresses the immunity. It decreases the production of lymphocytes. Blood cells are decreased, their migration and phagocytic potential is decreased, lysosomal membranes are stabilized, and also there is decreased inflammatory markers. Interleukin 1, which causes fever, is decreased. Phospholipase is inhibited. We discussed in our first lecture, phospholipase in the cell membrane can lead to production of phosphoinositol diphosphate and diacylglyceride, and this is a precursor for arachidonic acid, and arachidonic acid metabolism can lead to production of prostaglandins and leukotrienes. So by inhibiting this phospholipase, steroids are providing an opportunity to decrease production of prostaglandins and leukotrienes. So in combination, all these mechanisms help steroid hormones to combat the inflammation, to decrease the inflammation. And if there is already some inflammation, they can provide an opportunity for resolution. How? They will provide amino acids and proteins for repair. They will provide fatty acids for energy. They are going to provide glucose and likewise decrease the production of more inflammatory products. They can help resolve the inflammation. Other miscellaneous effects on blood cells, a very important aspect. As we just saw, they are causing decreased lymphocyte production, so there will be lymphocytopenia, eosinopenia, even basophils are decreased, but neutrophils are increased. RBCs are increased, platelets are increased. Blocks inflammatory response to allergic reactions. They can decrease the production of histamine and serotonin by mast cells and basophils. And last but not the least, a permissive action on epinephrine and glucagon. For epinephrine and norepinephrine, permissive action on specifically the vascular effects. If cortisol is not available, norepinephrine peripheral vasoconstricted ability is decreased. They are having a permissive action on receptor sensitivity of norepinephrine at the vasculature. Both for epinephrine and glucagon, cortisol has a permissive action in stabilizing and increasing the blood glucose level at the time of stress. So it's all about the functions of cortisol. I hope it's clear. So if you know the functions of these hormones, you can now guess what will happen if cortisol is in excess or deficiency. Let's have a look. If cortisol is in excess, there will be more, cortisol is in excess, blood glucose, you might guess it will increase. Proteins, hepatic protein synthesis will increase, but peripheral proteins will catabolize. And fatty acid metabolism, lipolysis will increase, and fatty acids metabolism will also cause ketosis. For somewhat anti-inflammatory effect is good, but in excess it will decrease immunity and make the person susceptible to increasing infections. And permissive action, if we look at it, the excessive cortisol might lead to excessive blood pressure, hypertension, because of excessive sensitivity to norepinephrine. And if we reverse all of it, cortisol is less, glucose might not be enough in case of stress. Blood glucose, the permissive effect is lost, the gluconeogenesis is less. In case of stress, the blood glucose might fall, leading to an crisis at the time of stress. Hepatic protein production might decrease, lipolysis and ketosis will be less, but the source of energy in case of stress will be lost, and the anti-inflammatory potential is useful, and that might not be present if the cortisol is less in amount. And a few other actions of cortisol. You do not need to remember these necessarily. Once you are done with the endocrinology module overall, you might be relating these better. So I have added these separately. Cortisol inhibits growth hormone production. We discussed when discussing the pituitary hormones. It decreases the thyroid stimulating hormone secretion and accelerates the maturation of surfactant at the time of fetal development, specifically in the last trimester. This is its effect on the blood cells. As we discussed, RBCs, platelets, and neutrophils increase. Lymphocytes, basophils, and eosinophils decrease by cortisol. How glucocorticoids are regulated. Starting from the hypothalamus, ACTH by pituitary, adrenal cortex is stimulated. Cortisol is having negative feedback to both anterior pituitary and hypothalamus. You can see there are other factors which are also stimulating or inhibiting hypothalamus. So trauma, pain, limbic system, emotion, circadian rhythm are stimulating the production of corticotrophin releasing hormone. These are afferents from the nucleus of tractus solitarius. This is in context with the orexigenic and anorexigenic potential. So this is not related with endocrinology right now, what we are discussing. So let's leave it over here. Moving on, we have a little bit of discussion in general endocrinology that peptide hormones are produced as first pre-pro-hormones, then processed to pre-hormones, and then tapered into their final form. This is what is shown over here, that whenever the ACTH is going to be produced, first a larger precursor protein will be formed, pro-opiomelanocortin. That pro-opiomelanocortin can be catabolized by this enzyme in anterior lobe and this enzyme in the intermediate lobe, and along with the ACTH there are going to be production of other substances too, like lipotropin, endorphins, and melanocyte stimulating. Endorphins, can attach to the opioids receptors and have the analgesic potential. Melanocyte stimulating hormone is also important. Why? Because in the skin, epidermis and dermis, we have melanocytes. These melanocytes have melanocyte stimulating hormone receptors on their surface, and once this receptor is activated, melanin can move into these melanocytes. More the melanin move into the melanocytes, darker will be the skin. If there is no melanocyte stimulating hormone, melanin will not move into it, and that can lead to a condition, um, albinism. That might also have other pathophysiology like absent melanocyte stimulating hormone receptors or defective melanocytes. Anyways, if there is more melanocyte stimulating hormone, more dark the skin will be. You can see along with the production of ACTH, melanocyte stimulating hormone is also produced, but this is what is majorly being produced in the intermediate lobe of pituitary gland. We discussed in our second session that intermediate lobe is rudimentary among humans. Mostly this step is going to happen in humans in the anterior lobe of pituitary gland, where melanocyte stimulating hormone is not obviously significantly produced. But the ACTH itself has melanocyte stimulating hormone activity, although less potent, but it is there. So ACTH, if produced excessively, can excessively stimulate this melanocyte stimulating hormone receptor, lead to the melanin transferring into the melanocytes, can lead to darkening of the skin. So in the conditions in which ACTH is more, there will be more pigmentation of the skin. And the conditions in which ACTH is lost, the skin might have abnormal pallor because the melanin is not moving into the melanocytes. We are done with the mineralocorticoids, glucocorticoids, and now we are going to have a look at the adrenal androgen. Most of the adrenal androgens are dehydroepiandrosterone. Mostly these are released in conjugation with sulfate. In extraadrenal tissue, these can be converted into androgens like testosterone. Among females, these are the only source of androgens and required for pubic and axillary hair. If for some reason adrenal androgens production is increased, you can guess what will it lead to. Increased androgens among the females can lead to virilization and hirsutism. So that's all for the functions, regulation, production, and nomenclature of the hormones for our adrenal cortex. We are now going to discuss the variations of these hormones production, excessive or less production, in a minute. I am going to take a break of 1 minute and then we will restart. Okay, let's resume our discussion. We are now going to talk about the abnormalities of hormonal production from the adrenal gland. So, starting from the hypoadrenalism means decreased production of the hormones from the adrenal gland. If there is decreased production of hormones from the adrenal gland, it might be there because of three reasons. There might be primary adrenal insufficiency. Adrenal gland itself has some defect, one of which can be caused because of Addison disease. Almost 80 to 90% primary adrenal insufficiency is caused by the Addison disease caused because of the autoimmune disorder. If the adrenal gland itself is fine, but there is decreased stimulation by ACTH because pituitary gland is not producing adequate amount of ACTH, again there will be hypoadrenalism, but this time this is secondary hypoadrenalism. If pituitary gland is also fine, adrenal gland is also working fine, but there is deficient corticotrophin releasing hormone production from the hypothalamus, again there will be hypoadrenalism of tertiary type. So hypoadrenalism is defective production of adrenal cortical hormones. Mineralocorticoids, glucocorticoids, androgens, all the three lines will decrease. Might be caused because of primary, secondary, or the tertiary reasons. So look at the gland itself and also at the hypothalamic and pituitary axis. Because once you are going to treat the patient, you are not only going to treat the symptoms, but also the cause. And first thing you need to do is to locate the cause. It is either in the hypothalamus, pituitary, or the gland itself. So whatever the cause is, once there is hypoadrenalism, there are going to be certain features that you need to worry about. How are you going to identify that a person is suffering from hypoadrenalism? That is by looking at its signs and symptoms. If the patient is having hypoadrenalism, mineralocorticoids are less, what will happen? If you remember the functions of aldosterone, you can simply tell. There will be hyponatremia, hyperkalemia, acidosis. When there is hyponatremia, decreased sodium reabsorption, decreased water reabsorption, and that can lead to hypovolemia, leading to an extent that it can also lead to shock. I hope it's understandable. Aldosterone's function was to conserve sodium and water and secrete potassium and hydrogen ions. If aldosterone is not there, though, everything will go in the reverse direction. Glucocorticoids' role was to stabilize glucose at the time of stress. If it is not there at the time of stress, there is a stress, there is a surgery, there is trauma, road traffic accident, there is an emotional stress, any type of stress the patient experiences, and there is no stabilization of blood glucose level. And that can lead to hypoglycemia, hypovolemic shock, and this what we call Addisonian crisis. The person might be okay otherwise. The other hormones might be compensating the deficiency of glucocorticoids and mineralocorticoids otherwise, but once there is stress, the stress hormone is not there, then the patient may collapse, and that is called as Addisonian crisis because it is happening in the Addison's disease, labeled on the name of the person who prescribed this. And lastly, lack of vascular responsiveness to epinephrine. Why is that so? Because at the level of vasculature, the alpha 1 receptors, cortisol has a permissive action on these. If cortisol is not there, the sensitivity to norepinephrine and alpha 1 receptors will decrease. And lastly, high ACTH. This is going to happen if there is primary hypoaldosteronism. Cortisol is less, What will be the negative feedback regulation? It will lead to enhanced production of ACTH. This high ACTH will still not be able to increase cortisol because adrenal gland is defective. There will be more and more and more ACTH, but no increase in the cortisol. But in case of secondary hypoaldosteronism, ACTH will be less. In case of tertiary hyperaldosteronism, ACTH will be less. So here this is about the primary hyperaldosteronism. If there is high ACTH, there will be more melanin pigmentation, specifically in the areas with the thin skin like mucous membranes, lips, and areola. Less, these are the less uh, frequently found actions of hypoadrenalism. So I have stated them separately, and this you will be able to understand once you have gone through the rest of the endocrinology. Let me give it a quick overview. Once there is lack of aldosterone, lack of glucocorticoids, blood glucose कम है, blood amino acids कम है, fatty acids, free fatty acids कम है, there will be less effective osmoles, less watery, and effective osmoles are less, but water is more. Renal GFR decreases, and ultimately that can lead to water intoxication. Anyways, these are the less important effects. You might focus on this and this and this major to identify the disease in your patient. That was all about hypoadrenalism. Now we are going to discuss the reverse of it, hyperadrenalism. If there is excessive production of adrenal cortical hormones. Once we talked about hypoadrenalism, we talked that it will have increased production of all the three lineages. Also, it will have increased production of androgens. It's missed over here. If androgens are excessively produced, what will happen? This is we are going to discuss later on, so that you can fit over here. And what will happen if there is less androgens? Okay, less androgens in males, testes will compensate for that, so males will have no symptoms for that. Among females, if that is post-pubertal, again the hair growth might regress a little but might not be significantly evident. Moving towards hyperadrenalism, it will again lead to production of excessive mineralocorticoids, glucocorticoids, and androgens, all the three classes of hormones from the adrenal cortex. The other name for this is Cushing syndrome. Hyperadrenalism caused by either primary, secondary, or tertiary causes can be labeled as Cushing syndrome. Here. But there is another type of hyperadrenalism too, in which only mineralocorticoids are in excess. That is Conn's disease. So I think this should be removed from here and left here. Cushing syndrome, in which all the three categories of hormones will be increasingly produced, and in Conn's disease, only aldosterone will be excessive. Once there is excessive aldosterone, there will be excessive reabsorption of sodium and water, hypokalemia, alkalosis, and muscle paralysis will be because of this hypokalemia of transient type. It will be primary, secondary, and tertiary Cushing syndrome. Primary will be if there is primary defect in the adrenal gland. For example, a tumor of the adrenal gland will produce high cortisol, high aldosterone, high androgens, and that will provide a negative feedback to decrease the production of ACTH. So if you have a patient with the symptoms of hyperadrenalism, in which cortisol is high and ACTH is less, you can expect this is primary hyperadrenalism. Next comes the secondary hyperadrenalism, in which the high cortisol is caused by the high ACTH produced from the pituitary gland, and this is also known as Cushing disease. It just has a historical significance rather than a functional difference. So if you are asked about the difference between Cushing disease and Cushing syndrome is a larger umbrella which involves all the cases of excessive adrenal cortical hormones production, and Cushing disease only involves those produced because of the pituitary gland. And tertiary hyperadrenalism is caused because of excessive corticotrophic releasing hormone by the hypothalamus. And there can be another reason, ectopic source. What ectopic is, I think this must be new for you. The word in English means something from that other than the original source. Like you had seen in the CVS, ectopic cardiac beat was produced from somewhere other than the SNO. So this is ectopic production of corticotrophin releasing hormone, or ectopic production of ACTH will be from somewhere other than the hypothalamus or pituitary gland. For example, lung tumor can lead to ectopic production of ACTH. Hypothalamus is fine, pituitary gland is fine, adrenal gland is fine, but a tumor is ectopically producing ACTH that will lead to excessive cortisol production, and that will be hyperadrenalism. And this you will fit into the secondary causes of hyperadrenalism. Although this is secondary hyperadrenalism, still this is not Cushing disease but the Cushing syndrome, but because this is not because of the pituitary but because of the high ectopic ACTH. Here you can also add ectopic ACTH. So the primary, secondary and tertiary hyperadrenalism. Moving on, if you are going to identify a patient with hyperadrenalism, next thing you need to do is to find out if he is suffering from primary, secondary or the tertiary hyperadrenalism. First thing you can see is to measure their cortisol levels. How will you measure it? If you measure it in the serum plasma, you might have a wrong assumption of hyper or hypocortisol production because it has a diurnal variation. What you can do is you can collect 24 hours urine sample and look into the amount of cortisol byproducts into it, or cortisol level itself. Anyways, once you have established that person has high cortisol levels, you will label it as a case of hyperadrenalism. Next step comes, you want to label is at primary, secondary or tertiary. Here ACTH will help you. You will next step you can measure ACTH. If ACTH is low, this is ACTH independent hyperadrenalism. This is primary adrenalism. If ACTH is high, you might think this is either secondary or tertiary. Next thing you would like to do is ACTH dependent Cushing syndrome. If is identified, you want to see either that ACTH is coming from the pituitary gland or by an ectopic source. You will do a test, dexamethasone suppression test. What is it? Let's see. Dexamethasone is a very potent glucocorticoid. So if you give this glucocorticoid exogenously, what would you expect is cortisol plus dexamethasone you have given exogenously. Actually, in normal person, what would happen? By negative feedback, ACTH will decrease. But if the person is suffering from secondary hyperthyroidism, ACTH will not decrease. Pituitary gland will keep on producing excessive ACTH. Cortisol and ACTH will both be still high. Low dose dexamethasone suppression test. You can now label it for sure that this is not a primary cause of hyperadrenalism but secondary cause. Next, you want to see if the secondary cause is pituitary or ectopic. You can again do the same test but with a higher dose of dexamethasone. If this is the pituitary cause, there might now be negative feedback suppression of ACTH and cortisol. But if it is Absolutely ectopic source, there will be no suppression this time. Moving on to the symptoms of Cushing disease or Cushing syndrome. What will happen? There will be more mineralocorticoids, more glucocorticoids, more androgens. Blood glucose level, of course, it will increase, leading to adrenal diabetes. Very simple. Proteins catabolism will now increase. That can lead to muscle weakness. Abdominal purplish stria. What are these? Because of catabolism of subcutaneous proteins, thin skin, subcutaneous collagen, that can lead to weakening of skin, and purplish stria will become prominent on the abdomen. Poor wound healing, again attributed to decreased availability of proteins. Bruisability, again collagen in the vascular walls is less. Osteoporosis, again decreased protein deposition in the bones. All these caused because of the increased protein catabolism. Fat redistribution and water retention. Water retention because of hyperaldosteronism. Fat redistribution, as we discussed while discussing the cortisol functions, that it increases lipolysis but also causes deposition of lipids in certain areas of the body. So ultimately what will occur, the peripheries will be thin, but there will be excessive deposition of adipose tissue in the upper torso. It will become buffalo-like torso in the face, caused both because of fluid retention and the fatty deposition. Moon-like face will form. Facial plethora, characteristic symptomatic features of Cushing disease. Pot-like abdomen, again pendulous abdomen because of the fatty fats redistribution. Lastly, excessive androgens in males might not be evident much, but among females, it can lead to hirsutism, excessive hair growth, male pattern hair growth, virilization, and acne, also caused because of the androgens. Same features: buffalo-like torso, pendulous abdomen, abdominal stria, poor muscle development, poor wound healing, thin skin, bruisability, facial plethora, moon-like face. And this is the picture of original patient taken from Sherwood Physiology. This is the before development of Cushing syndrome, and this is after the Cushing syndrome. You can appreciate the moon-like face and facial plethora over here. And here is a combination of few treatment options for whatever the disorders we have discussed till now: hyper or hypo adrenal cortical hormone productions. Let's see. Can you guess where these were? If there is hypoadrenal cortical hormone production, you can give exogenous cortisol. If there is hyperadrenalism, for example, Conn's syndrome, you can give ACE inhibitors, angiotensin converting enzyme inhibitors. That might lead to somewhat decrease in the production of aldosterone. Block steroidogenesis. Again, if there is hyperadrenal cortical hormone productions, these drugs might inhibit the conversion of cholesterol to pregnenolone. Inhibit ACTH secretion. How it can be done? If there is excessive ACTH, these serotonin and GABA inhibitors can lead to decreased production. Aldosterone antagonist. If there is Conn's syndrome, again, these can be antagonized at the receptor level. Exogenous ACTH in case of hypoproduction of adrenal cortical hormones. Do not read to memorize all these, but this is just a conceptual exercise. If there is deficiency, give from outside. If there is excess, do something to antagonize. Okay, this is again exercise for you. Before listening to the rest of the video, I would like you to exercise. What do you expect will happen to plasma cortisol, ACTH, and skin pigmentation in these diseases? Primary hypercortisolism. Yes, of course, plasma cortisol will be more. Negative feedback, ACTH will be less. When ACTH is less, hyperpigmentation will not be there. Secondary hypercortisolism because of Cushing disease, caused because of excessive ACTH, that will cause excessive cortisol. ACTH is more, there will be hyperpigmentation. Again, ectopic ACTH, it's more, it will cause more cortisol, more pigmentation. Hypocortisolism, cortisol will be less. Primary है feedback to increase ACTH, that ACTH will cause pigmentation. Secondary hypocortisolism is caused because of decreased ACTH. Cortisol will be less and ACTH is less, so pigmentation will be less. So I hope you had done it fine. Adrenogenital syndrome, as I discussed previously, if there is excess of androgens, what symptoms you might find? If the male has gone through the puberty. After puberty, excessive androgens will not be a problem for the males. But before puberty, if there are excessive androgens, that can lead to precocious pseudo puberty that you have seen in the reproductive physiology, early onset of puberty without gaining the actual spermatogenic and reproductive potential. Among females, again, if this is caused before puberty in the fetal life, early neonatal life, this adrenogenital syndrome might lead to genital changes, clitoral hypertrophy to resemble penis wave. And if it is after puberty, these things can happen. Virilization might include beard growth, horse-wise baldness, masculine distribution of hair, masculine characteristics of skin and muscles, acne, so virilization, hirsutism, and genital changes. Lastly, the hormonal deficiencies, as I said when discussing the production of these hormones, mostly 21 beta hydroxylase deficiency and less frequently 17 alpha hydroxylase deficiency. If 21 beta hydroxylase is deficient, what will happen? Nothing will be produced below this. All the precursor will be shifted to the production of androgens. There will be adrenogenital syndrome in the females. Males might not have much problem with the androgens, but both males and females will have mineralocorticoid deficiency, glucocorticoid deficiency. In comparison, if the patient is suffering from 17 alpha hydroxylase deficiency, all this will be blocked. There will be no production of androgens, no production of cortisol, but excess production of aldosterone. Symptoms will be similar to that of the mineralocorticoid excess. This is the summary of the deficiency of hormones and the rest of the symptoms. I hope now you can all guess what happens if there is excessive or decreased mineralo or glucocorticoids. We have discussed this all, the Addison disease, primary adrenocortical insufficiency, Cushing syndrome, primary, secondary or tertiary. Cushing disease is secondary adrenocortical production. Con syndrome is primary hyperaldosteronism only, and the enzymatic deficiencies, the clinical features, ACTH level, treatment options. We have discussed all that previously. These are the summary tables for you to revise if you want. And that was all for the adrenal cortex. Lastly, 2-3 slides on the adrenal medulla, though these are discussed in detail with the context of autonomic nervous system. Let's have a little bit of comparison. Adrenal medulla produces both norepinephrine and epinephrine. 80% of epinephrine, whereas at autonomic nervous system endings, mostly it was norepinephrine, and here it is mostly epinephrine. If there is a tumor of adrenal medulla, that can lead to increased production of these catecholamines, and that is known as pheochromocytoma, a characteristic symptom of which is hypertension and episodic hypertension because of excessive epinephrine. Metabolic functions, if we see from epinephrine, so let's see what happens. again it is going to provide the substrates at the time of stress. So mostly it is going to do what cortisol did. It is going to increase the lipolysis. Instead of storing the fats, it will lead to availability of fats for production of energy. It will lead to increased muscle glycogenolysis. This is something which cortisol had not done, epinephrine is doing. The stored glycogen is catabolized to form plasma glucose indirectly with the help of liver, of course. That's your biochemistry knowledge. What else it is doing? It is increasing the glycogenolysis in the liver too. It is increasing gluconeogenesis in the liver. What is the ultimate effect? That is increased plasma glucose, increased plasma fatty acids. No effect on the proteins you can see over here. Mostly increased plasma glucose and increased fatty acids by lipolysis, by glycogenolysis, and by gluconeogenesis. Whenever there is lipolysis, this is by increasing the activity of a hormone sensitive lipase. Either it is growth hormone increasing lipolysis, cortisol, or epinephrine, the hormone involved at the level of adipose tissue, it will be hormone sensitive lipase. So, last slide. Epinephrine produced from adrenal medulla. Once there was sympathetic nervous system stimulation at preganglionic sympathetic nerve endings over here, acetylcholine will be released. And rather than postganglionic nerve endings, we have modified cells of adrenal medulla which can produce epinephrine and norepinephrine, which will work in combination with the autonomic nervous system and other stress responses to combat the flight and fight situation. So that was all about the quick review of adrenal medulla. We are done with the discussion of adrenal cortical hormones and a bit of overview of adrenal medullary hormones. If you have any questions, any suggestions, please do not hesitate to write down in the comment box and I will be there to answer your queries. Till then, till we meet next, I wish you all the very best. Take care and goodbye.